heart failure endpoints consisting of heart failure hospitalization, urgent heart failure visit or CV death and all-cause death. So they compared these patients 1-to-1 randomization of nearly 17,000 patients. They compared Wegovy 2.4 with placebo along with the standard of care, which would be adequate medical treatment with for lipids, high blood pressure, antiplatelet therapy were indicated, and also glycemic control for those developing type 2 diabetes during the study. And also healthy lifestyle guideline including weight loss where appropriate, increase in physical activity, smoking cessation and limiting alcohol consumption. And these were all suggested to all the centers who participated in the trial. What they found is that there is nearly 20% reduction in the risk of MACE, that is CV death, non-fatal MI and non-fatal stroke. There was a significant reduction, and what we can see in this graph is that the reduction in risk was quite early on, even before they found significant weight loss. This could be because of the pleiotropic effect of the GLP-1 receptor agonist. Hence the drive to consider GLP-1 receptor agonists like semaglutide with proven cardiovascular benefit in patients with obesity and increase in cardiovascular risk. The separation of MACE, as I said, was achieved before maximal weight loss was achieved, and 80% of the MACE risk reduction with Wegovy is mediated by factors other than body weight loss, and the MACE risk reduction was independent of the change in body weight. And the maximal weight loss was achieved by 14 months in this study. And Wegovy showed consistent beneficial effect across all CV outcomes that were measured, including the composite heart failure outcome. There was an 18% reduction and 15% reduction in the risk of CV death in the Wegovy group compared to the placebo. These are the other cardiovascular outcome trials for other anti-obesity medications in the past, and most of them have not been really successful, either because of increased CV risk like in sibutramine, the SCOUT trial in the early 2000, the Crescendo ribonomab stopped early as the drug was withdrawn. The naltrexone bupropion trial, the LIGHT trial was stopped because the interim data was leaked. The naltrexone bupropion trial, again the CONVENE trial, was stopped early because the drug ownership changed. With lorcaserin, the non-inferiority was demonstrated, but the drug was withdrawn because of excess cancer found in animal studies. So after that we have the SELECT, which looked into the semaglutide 2.4. This is the relative risk reduction compared to the non-users. The MACE3 reduction 43%, revised MACE3 57%, CV related mortality was 73%, and all cause mortality was reduction by 86%. Summarize, Wegovy 2.4 mg is suitable for adult patients from a BMI of more than 27 in the presence of at least one weight related comorbidity or more than 30 regardless of any comorbidity. From these clinical trials, we found that there is more than 20% weight loss seen in at least 1/3 of our patients, and nearly 50%, more than 50% loss, more than 15% of weight. Sustained weight loss was found in more than 4 years, and there was a 20% significant reduction in MACE. Thank you for coming here, and questions are welcome.
Now, the both sessions are for open discussion. Madam, one question to you. What about the oral semaglutide, madam? Is it available? Whether it is because the side effects are, it seems side effects are lesser in oral semaglutide, especially the gallstones. Then what about diabetic retinopathy? That is slightly higher in that is injectable semaglutide than the oral semaglutide. What is your opinion?
Okay, diabetic retinopathy getting worse has been described in other GLP-1s as well, and mostly it is related to the rapid reduction in the blood glucose, but not a significant difference found in the latest trials. But this has been described before even semaglutide or or any the latest GLP-1 molecules. But I don't think so. I've found a difference in Rybelsus, which is the oral semaglutide, and Wegovy, which is the injectable one. When it comes to side effects, GLP-1 as such are not really well tolerated if the patient does not take their food the way we ask them to take. They're supposed to take it in small quantities but more frequently. But most of our patients are used to dumping a lot of carbohydrates, and hence they get those symptoms of GI intolerance. But when we advise them to take in small quantities, they tolerate it better, and the GI intolerance like dyspepsia can be managed with antacids.
So madam, still the practitioners are hesitating to use this GLP-1 receptor agonist in non-diabetic obese patients, fearing hypoglycemia. So actually the semaglutide can be used for non-diabetic also, isn't it madam?
Yes, that is what this trial shows, that Wegovy can be used, and all these trials that I presented is non-diabetic obese patients. It can be used, but we'll have to select our patient and introduce the molecule. It's not for everyone. The patient has to be really well motivated to go on GLP-1, because they'll have to put up with the side effects to some extent.
Can it be used for a non-obese diabetic? A non-obese, a normal weight, normal BMI diabetic, can you use this GLP-1?
You can still use this molecule, because the primary aim is not just weight management. It's got good cardiovascular outcome. So it has got, because of the pleiotropic effects, patients with high CV risk, this comes even before any other oral hypoglycemic agent. So that is what the AACE and ADA recommendation is. Even in a lean diabetic with high cardiovascular risk or established cardiovascular risk, you can still use the GLP-1.
The patient, how long we have to use? You said even if we discontinue, the benefit lasts for 4 years, then only. So the patients, when we suggest to the patients, they ask how long I have to take this drug, sir. What answer we can give?
No, this trial actually showed that the benefit was maintained as long as the patient was taking it. When you stop, the benefit is gone. They all gain the weight back.
So it's a lifelong one.
Yes.
Lucid presentation. Both the presenters, your presentations are extremely good. Right. My question, it's a tricky one. Right. You have oral formulation Rybelsus. So cardiac safety has been established with reference to Pioneer 6. Pioneer 6, cardiac safety of oral semaglutide. Next SOUL trial established the cardiovascular efficacy of Rybelsus. Right. We have Wegovy. So this select trial clearly shows the benefit in terms of risk reduction of cardiovascular event much more greater than oral semaglutide. Okay. Now the question is, which patients you will prescribe Wegovy, to which patient you will prescribe Rybelsus?
That comes to discussing the options with the patient. If the patient prefers an injectable or doesn't mind going on an injectable, Wegovy. If the patient is happy to take an oral semaglutide and is compliant, because with the oral Rybelsus, the compliance is the main thing. They don't take it with the smallest amount of water, they don't keep it in empty stomach. But if the patient is able to adhere to all that and does not want an injectable, oral Rybelsus is still an option.
Now the patient has a BMI of 27 plus multiple risk factors, and you want to put the patient on Wegovy, but the cost is very high.
Yes.
Will you convince the patient to go for Wegovy?
Sir, in our Indian system where the patient has to pay from the pocket, we'll have to be very careful looking into the financial status of the patient. I don't want to lose a patient completely. I don't want to say go and take a molecule that's so expensive and the patient completely disappears from my radar. I want to make sure the patient is compliant with the medication that is useful. So when it comes to financial implications, of course Rybelsus is less expensive than Wegovy, but I'm hoping things will change and we'll have more affordable injectable semaglutide. So in that case we can go for the injectable. At the moment Rybelsus is less expensive and hence we can use Rybelsus in a patient who is conscious about the cost.
Actually, madam, I have a patient, BMI more than 30 with established cardiovascular disease. Patient has been already on some other brand. So I convince the patient in such a way that this particular drug will prevent the cardiovascular events. You are going to spend 17,000 rupees per month. On the other hand, if you develop one cardiovascular event, this will fetch you not less than 4 lakhs. Not less than 4 lakhs. The thing is, the benefit is real, so why don't you put? Patient accepted.
I would just like to add one thing to Dr. Shanmugavelu's comment, that convincing is not may not be the right word. So I think as a physician we should be informing the patient that yes, you have this disease, there is a trial, there is a benefit, and if you take this then these are the additional benefits. Then we leave it to the patient's choice. If he is not affording, obviously we cannot push the patient to take the drug, but if he can afford, then obviously we know the benefit. So I think informing the patient is the right answer for this.
These drugs are known to cause muscle mass loss. Is it the loss of muscle fiber or intramuscular fat loss? What is your opinion?
I think there is loss of both visceral and muscle mass, but if the patient does not take enough protein, then there will be actually loss of the muscle mass itself, not just the fat. So whenever you encourage your patients to lose weight, the general idea is that they lose 2/3 of fat and 1/3 of muscle mass. So there are ongoing studies, I think by Dr. Nitin Kapoor at CMC Vellore and a few other centers looking exactly into what you are asking, looking into if it is just the fat or actually the muscle mass. There are ongoing studies to try and look into it.
One more ongoing study with semaglutide and monoclonal antibody, bimagrumab, that is combination. This will stimulate muscle protein synthesis, bimagrumab, prevent the muscle mass loss in a patient already on semaglutide, because this trial they are using 7.2 milligram of semaglutide currently ongoing, sir.
Yes, there are much higher, I think it's step up trial looking into much higher dose of semaglutide.
If no further questions, we could conclude the session by thanking both the speakers and for having given me the opportunity to chair the session.
Thank you.
Thank you.